different kinds of numbers. I'm not going to mention them. So if you don't know them, don't worry about it. Just know that any blood pressure over 140 over 90 is concerning. Initially, pulse rate will increase, but then will go down. I'm going to skip vena cava for 1 second and go to hypercoagulable. Women during pregnancy are hypercoagulable. All of their clotting factors are increased. Now, that can be good. Probably started way back at the beginning of creation because we didn't all have Pitocin or oxytocin to get after we deliver our baby to prevent us from hemorrhaging. So, God, Buddha, Allah, Mother Nature, Yahweh said, hey, let's just make them clot a little bit faster so after they deliver, they don't bleed to death. Hey, that's a good idea. So we don't really need that now because we've got the wonderful oxytocin to take care of that. However, it can cause problems. What kind of problems can you get with a hypercoagulable state? Blood clots, stroke, cardiovascular events, let's say. Adverse cardiovascular events is a good word. That means strokes, heart attacks, things like that. Pulmonary embolisms from the blood clotting, okay? So are all pregnant women at increased risk for all of those?
Yes.
Yes, they are, okay? What about a woman who's taking oral contraceptives? Is she at increased risk for those?
Yes.
Yes, because combination oral contraceptives, progestin and estrogen, cause a hypercoagulable state similar to that of pregnancy. So the risk factors for all of those adverse cardiovascular events are at an increased rate. However, the OCs in a normal healthy woman less than age 35 who does not smoke is less than being pregnant. So they're still safer, which is why we take them. If they were not as safe as being pregnant, we probably wouldn't have that balance and we wouldn't be using them, okay? So yeah, we're all at increased risk when you're pregnant and also if you take oral contraceptives, okay? So what is vena cava syndrome? Vena cava syndrome is the reason we tell women, once your uterus pops out of your pelvis into your abdomen, please no longer lay flat on your back. And when does that uterus pop out of the pelvis? At 13 weeks, that's right. So after that, we don't want them to lay flat on their back. That does not mean they've got to plank themselves on their sides. Okay, we're just talking about putting a little pillow underneath the hip. Okay, so that the gravid uterus, the pregnant uterus, is not compressing. I'm so graceful. Not compressing the vena cava, because the vena cava is a large blood vessel, and it's regulating the blood flow back to the heart. So let's say your vena cava is obstructed because you have a big gravid pregnant uterus obstructing it. What kind of symptoms will the mother have?
Her blood pressure is going to be affected.
Big word for the blood pressure. Hypotension.
Hypotension.
How else might she feel?
Fainty, dizzy.
Fainty, dizzy, absolutely. So that's kind of inconvenient. But remember, if she's hypotensive, regardless of the cause, and that means her blood pressure is lower than normal. If she is hypotensive, she is not perfusing her vital organs. Brain is pretty vital. Heart, lungs, kidneys, and now add on the placenta. So if mom is hypotensive from vena cava syndrome, or as we'll learn from an epidural, big cause of hypotension in delivery, she's not perfusing her organs properly, including the placenta. And the placenta is the only way the fetus has to get oxygen. Okay, so that's a concern. That's why mom doesn't lay. You see how all that kind of goes around? When you can think of vena cava syndrome and you can understand the anatomical and physiological impact of that and why that's not a good thing, you have just participated in critical thinking. Did you know that? So you took some pieces of knowledge and information, you put them together, and now you can make a plan on that. And so our plan is to what with our patient? Tilt their hip when they're with us, or teach them to not lay flat on their back. Okay? That's critical thinking. Sometimes we talk about critical thinking as this thing out in the sky. Will we ever get it? I don't know. I don't know what it is. I don't think I got it. I want my money back. all you're really doing with critical thinking is breaking it down into teeny little pieces of information and then start putting them together. Start talking to yourself about it. You know, when I graduated in 1978, I couldn't have said what I just said, even though I knew that. And I guess I was minimally competent because I passed the NCLEX. Although we did use, you know, like rocks and things to, you know, write in the sand, but just kidding. But anyway, so that's what that is. That's important. Questions about those 4 things? Those are important. Okay, respiratory system. The volume increases. Why? Because we have to increase our oxygen consumption. So they're breathing deeper. However, at one point during pregnancy, when the uterus comes up very high into the abdomen, women will find themselves not breathing abdominally like we do now, like we can see our abdomen move sometimes if we're breathing really deep and heavy now, but they'll become more thoracic breathers because they can't do anything down there because everything's pushed up and they're all squished up and they can barely take a deep breath. They can't even eat. They feel like they had a lap band surgery or something. They can just eat this much food at a time because their stomach is so compressed by the uterus coming up. Okay? So the volume increases and the type of breathing becomes a little bit different later on. The GI system. Yes, we have gingivitis and bleeding. What's gingivitis? Inflammation of the gums. Gum care during pregnancy is very important. Poor dentition, poor gum care, gingivitis, and what's the one when they're like infected? I can't think of that word I want to say. Whatever. Bad teeth are highly related to preeclampsia and preterm labor for whatever reason. Just it's a risk factor. So brushing regularly, flossing, we should all be doing that, but definitely during pregnancy. They can have regular dental care, but it probably, when you're pregnant, isn't the best time to get like, you know, veneers or caps or whatever we call them now on all your teeth because you want to be pretty at the delivery. Probably not the best thing, you know. So major dental care is not a good thing. What about pyrosis? What's that?
Heartburn.
Heartburn, yes. Heartburn, what causes heartburn in pregnancy? Well, a couple things, an anatomical reason. So as the fetus grows up and puts pressure, then you can get reflux because of the pressure pushing up. Also, hormonally. Which hormone is going to contribute to that? Progesterone. Because progesterone, the one that maintains pregnancy, it does that by relaxing the uterus, because the uterus is a smooth muscle. Progesterone relaxes smooth muscle. And where else in our body do we have smooth muscle? All in your GI tract. From here to here. Okay? So it will relax. So progesterone is one of the causes of heartburn because it relaxes and you get reflux. Also, very highly related to constipation in pregnancy because it slows down peristalsis, relaxes the smooth muscle of the bowel. What will your patient tell you caused their constipation?
Iron.
In their prenatal vitamins. And so what did they do?
Stop taking it.
They quit taking it because it caused them to be constipated. So what intervention would that patient require? Teaching, yes, teaching. So no finger pointing, just teaching. Now, does iron promote constipation? Yes, okay. But in pregnancy, it's also very related to progesterone, and they need iron. Okay, it's like the only element that they cannot consume enough food to get enough of that they need in pregnancies. So, yes, they need the iron, and we want them to take the prenatal vitamin. So, what do they do about constipation?
Eat more prunes.
They do the same thing you and I and every other person on the earth would do. Increase fluids, increase bulk and fiber. Don't do fiber without fluids though, right? Because then you're really in trouble. So increase grains, fresh fruits, vegetables, and fluid intake. Okay? And Colace is fine. Colace, sometimes more than one a day, is fine. Excuse me, I need to look at this one. Okay, so I put constipation and hemorrhoids together because if you have constipation and it's not treated properly in a relatively short period of time, you're probably going to get hemorrhoids. That plus the pressure of the fetus on the rectum will also cause hemorrhoids. Sometimes hemorrhoids occur at the time of delivery. So hemorrhoids can be a problem for pregnant women. Sometimes they're not. Sometimes we see them and it looks like a little bunch of grapes. And we're like, wow, look at that, I've never seen such a thing on a rectum before. Ask your patient, have you had trouble with hemorrhoids? And they'll be like, no, thank goodness. My sister did, but I didn't. And you're looking at them like, wow. Because the symptom of hemorrhoids is really in the head of the person. So if they're really symptomatic, then we're going to offer a lot more treatment. If they're not bleeding, they're just there. Now, are you going to go poking hemorrhoids back in? No, you do not. Could someone recommend to the patient to poke their own hemorrhoids back in? Because that's what they are, prolapsed veins. Yes, they can. Patients can do that. The difference is they know when to stop. If it hurts, if it doesn't feel right, they'll stop. We don't have the sensation of pain, so we wouldn't stop. Okay? Gallstones. Because of the progesterone, all of the GI tract, that smooth muscle, including the gallbladder, will slow down. And so gallstones will develop because the bile in the gallbladder will be expressed out more slowly. So you have more retention of the bile, sits around more, and you get gallstones. Same happens with oral contraceptives. Women who take oral contraceptives are at increased risk for gallstones too. We already talked about UTIs, urinary frequency, dysuria, urgency. Pregnant women are at increased risk for UTIs because of the stasis of urine in the bladder. Okay. That's usually the primary reason. If they're diabetic, obviously that's going to have an issue too, because if they have glycosuria, they're more likely to have an infection. I think perspiration is misspelled. I don't know what right to me. Should there be an I right there? I think so. So, changes in the skin. Yes, it's warmer and increased perspiration, even though it's not spelled correctly. Hyperpigmentation. What gets darker? What part of your skin gets darker?
The nipples and the areola.
The areola and the nipples, which we already saw a picture of.
Sometimes their face.
You get the black stripe.
Linea nigra. This is a line from the umbilicus to the symphysis pubis. Remember, the symphysis pubis is a what? What is it made out of? It's a bone. The symphysis pubis is a bone. And I say that because in order to know where the symphysis pubis is, we cannot use our eyes. What would we have to do?
Palpate.
You would have to palpate, okay? So you palpate for the symphysis pubis. Anytime you want to know where it is, you have to touch it. So this is a dark line called linea nigra. It does fade and go away after pregnancy. It's more common in darker skinned women, okay? But it can be in anyone. So that has hyperpigmentation to it. And also, women can get something called melasma or cholasma, or it's like a butterfly rash. If you notice in this woman, I don't know if you've studied anything about lupus, but those women have a butterfly rash. So you can see here's the rash, and here's the rash. This will fade after pregnancy. This can also occur with oral contraceptives, and the only way to make it go away is to stop them. So now imagine the emotional state of this woman. She has an unplanned, even though not unwanted, but unplanned pregnancy. She's constantly going to the bathroom. She's nauseous, right? She's getting bloaty and her pelvis feels all full and bloaty. And now she gets a rash on her face? Is she a little cranky? A little bit. Yeah, she's a little bit focused on herself and a little bit cranky. So melasma and cholasma and linea nigra and the hyperpigmentation changes of the areola and the nipples, that all goes away. Connective tissue changes, we get striae. What are those? Stretch marks. Do you have to be pregnant to get them?
No.
If you use the cream from the 2 peas in a pod at the baby store, will you prevent them? No. Well, it worked for some famous woman, I forget who it is. These are what some striae can look like. They, in the beginning, will be very fiery red. And I've seen women who even look worse than this. And this is not good. And it does not go away. And there's nothing you can do. Afterwards, if you have ever seen stretch marks on anyone, they do fade, they become silvery or opalescent in color, they're no longer red. But rapid weight gain can do that. But what really can cause this is just poor collagen. And the creams, nothing you can do will stop it. Gaining the proper amount of weight in pregnancy and not gaining too much weight outside of pregnancy might help, but it's usually hereditary or familial, and it's a collagen problem. And so, do they go away?
No.
No, they don't. They change. Does the hyperpigmentation go away?
Yes.
Fades and goes away. Although I know in just last semester, the semester before, one of the students said, mine never went away. And as she discussed it, stood up and showed us all that she still had her linea nigra from her pregnancy.
But the stray goes away?
Just saying.
Are you saying, did you say the stray goes away?
No, the striae does not go away. It changes though, Sadia. It becomes silvery, opalescent, pale looking. But they do not go away. There are several of us that could probably show you some. But
That will come from my
in
understanding.
pregnancy, because it's in the acute stage, this is what it looks like.
And it's not acute.
And it's not cute. No, it's not. Okay. Hair does have an increased growth during pregnancy. Yes, it does. A lot of women will tell you it's because of the prenatal vitamins, but it's really the hormones in pregnancy. Vitamins don't hurt.
She says, pregnancy hair is the best.
Yeah.
That's the only good thing you'll get out of pregnancy.
Well, it does kind of give you a glow. And that's because you're sweating. Okay, so here's a question. Vital signs of a pregnant woman in her 3rd trimester are being assessed. The woman who is lying supine complains of feeling faint, dizzy, and agitated. Which nursing intervention is appropriate?
D.
D. What'd you say, B or?
D.
D.
Dog.
D. Have the patient turn to her left side, recheck her blood pressure.
Is this because...
So A, you don't want her to stand up, for goodness sake, she's faint and dizzy. That'd be a cuckoo thing to do. Have them lie down and hold her arm in a dependent position. No, said anybody ever, because holding the arm at the level of the heart is appropriate. Have the patient lie supine for 5 minutes. No, that's just doing the same thing. So having her turn on the left side. Okay, rechecking in 5 minutes. Anybody disagree?
This is about the vena cava syndrome?
Yes.
Oh, okay.
Yes, see, it doesn't say that though, does it?
I just had a picture in my head, so...
Yes.
Okay.
So you're exactly right. That's perfect. Because some of my questions will look like that.
Oh,
It's about vena cava syndrome, but I didn't tell you that.
well,
You have to know that
I just
by what
thought...
I've described to you. Does that make sense?
Yes.
I think those are NCLEX questions. They don't always say, here is a patient with XYZ. It's going to describe some symptoms, positive, negative, whatever, and ask you what to do. In the meantime, reading that, you have to pull out and know what it is that they've just described. And that's very common. Okay, musculoskeletally speaking, pelvic joints relax. They do that because of a hormone called relaxin, which occurs during pregnancy. And it does that so that as their center of gravity changes, like your center of gravity, ours right now goes right down the middle of our body. If we put a, stick right through the middle of our body like this, that's where our center of gravity is. Now add a big gravid uterus out here though, and we've got to compensate for that somehow, or we'll just topple right over, or backwards, or some way. So we like to widen our stance. And we can do that because our hips have been relaxed. And then when you are trained in your eye, you'll be able to walk behind a pregnant woman and not even see her belly and know that she's pregnant because she's doing what?
Wow.
She's waddling, and you'll know it. Now there could be some other problem, like a hip problem, but probably not. So that's normal, relaxing of the hips. If you've seen a vaginal birth, And of course, God, good old Mother Nature, always said, oh, we're going to deliver vaginally. We didn't know we were going to do cesareans on 33% of the population. So, you know, they weren't preparing us for that. They're preparing us to get our knees to our ears so that we can open up that pelvis and shoot the baby out, okay? And that's pretty much where they're going to want to put your knees when you're delivering, is around your ears. So that's all normal though. Okay. What's not normal is diastasis recti. I don't know if you've ever seen this before, but this is a separation of the abdominal muscles. And I have never seen it when it's actively happening in a patient. I have seen it several times afterwards. When it's happening, it's painful because your muscles are ripping apart. Like, and this person is never going to have an 8-pack again, because you know it's really not a 6-pack, it's an 8-pack if you go far enough down. There's an 8-pack of muscles there. But they're never going to have that again. Well, they might, they'll have double. But there's only one way to fix it, and that's surgically. And guess what? Most insurance companies don't pay for it, because it's considered cosmetic. Okay? Now, if you're a big old fat person, you probably won't be able to see it, nobody will know. But if you're a thin person, just looking at them from the outside, yes, you can see it very clearly, especially when they're lying prone. Okay? So that's a possibility in pregnancy. Definitely not as good as the hair growth. So HCG, or human chorionic gonadotropin, is the pregnancy hormone. That is the hormone that we test in the blood and in the urine for pregnancy. That's the pregnancy hormone. Okay? Now, in the old days, human chorionic gonadotropin pregnancy tests, especially the urine ones, were not very specific. Nowadays, they're very specific. They can detect a very small amount of HCG in your body. Okay? So if you do the first voided urine in the morning where it's concentrated in your urine, if you're just the least little bit pregnant, even probably before you miss your menstrual cycle, or definitely by that time, a urine test will be positive. Obviously, a blood test will be positive sooner and be more specific. Because what a urine test does is give you a qualitative result. It either says, yes, you have the hormone, or no, you don't. When you do a blood test, you can do that same test, yes or no, or you can do one that gives you a number. In the beginning of pregnancy, those numbers can be very, very important. Later on, after 4 to 6 weeks of pregnancy, doesn't matter what the numbers are because the normals are so wide ranged. So a normal at 8 weeks of pregnancy might be 60,000 units of HCG to 450,000. Do you see what I'm saying? Such a wide range, it means nothing. But in the beginning of pregnancy, that number should double every 48 hours. So if we're watching a patient who we're concerned about, we can do that number. And that's called a quantitative beta HCG. And those are, you know, all blood tests, or all tests are like that. They're either qualitative or quantitative. Okay, in this case, this one can be either. So HCG is the pregnancy hormone. Note, all of these are placental hormones. What does that mean? They're secreted by the placenta. Now we know that the progesterone isn't like right at the beginning, but it will be. Where does the progesterone come from in the first few weeks?
The corpus luteum.
Corpus luteum. But there are 5 major hormones that are secreted here by the placenta. HCG, the pregnancy hormone. Estrogen. You know what estrogen does? It makes everything bigger. What's it make bigger? Your breast, your bottom, the pregnant woman's breast and bottom, the uterus. Okay, it makes everything grow and it's bigger. Okay, that's its major thing. It's making everything bigger. Progesterone is doing what? Maintaining pregnancy by relaxing the uterine muscle and other smooth muscle, but relaxing smooth muscle. Relaxin, we already mentioned, its primary responsibility is to relax the joints of the pelvis for the process of labor and birthing. This little devil here, human placental lactogen, is the whole reason there is such a thing as gestational diabetes. This is the cause of gestational diabetes. Well, you know, kind of
What is
poking
it?
a little too much. But it really contributes, because what this does, this hormone,
Placental lactogen.
human placental lactogen, or HPL, prevents, it antagonizes the insulin, so it doesn't work. What does insulin normally do? It goes and unlocks the door to the cell and lets the sugar in for energy, okay? Without insulin, your cells don't get unlocked and your glucose doesn't get in for energy, okay? This does the same thing. It antagonizes the insulin. So it keeps it from unlocking the door and letting the glucose in. Well, that's ridiculous. Why does it do that? So that the fetus has access to the glucose for growth. So HPL is all about the fetus. It's to get the fetus glucose. But because of that, it leaves our mothers having elevated levels of glucose. So if we have a really healthy pancreas in our mom, she's probably going to be able to handle it. Just going to secrete a lot more insulin. However, if she's got a little tendency to have a low amount of insulin, or it's not functioning as well, like a pre-type 2 diabetic, then probably they're going to zip right on into gestational diabetes. Does that make sense? So the HPL is really for the protection of the fetus.